A very good morning to everyone. I think few students are yet to join. We'll wait for them for 2-3 minutes and I'll start them. So let me begin with the class. So till now we had discussed about the infectious disorders of the nose and the paranasal sinuses, inflammatory disorders of the nose and the paranasal sinuses, and the traumatic conditions of the nose and the paranasal sinuses. So today in my class I'll be discussing about the benign and the malignant neoplasms of the nasal cavity, and in the next class on Monday Dr. Soumya will be discussing about the benign and malignant neoplasms of the paranasal sinuses. Okay, so let me start. Coming to the incidence of the benign and the malignant neoplasms of the nasal cavity, it's very rare. It accounts for up to 3% of all the tumors in the body. So within the nasal cavity, the 50% of the tumors are benign in nature and rest 50% of the tumors are malignant in nature. So most of the tumors of the nose and the paranasal sinuses, they are most commonly seen within the elderly males. So the differentiation of the tumors between the nasal cavity and the paranasal sinuses is always very much difficult. So the nasal cavity can be invaded by the growths from the paranasal sinuses, nasopharynx, cranial cavity or buccal cavity. So how do you differentiate the benign lesions from the malignant lesions of the nose? So the benign lesions of the nose, they are usually smooth, they are very well localized, and they are always covered with a mucous membrane. Whereas the malignant lesions, they are usually friable, they have the granular surface and they tend to bleed easily. So what are all the predisposing factors for these tumors to develop? Most commonly, it is the exposure to the wood dust, which can predispose to the development of the adenocarcinoma, nickel refining processes, which can result in the development of the squamous cell carcinoma, industrial fumes, leather tanning, and cigarette smoking and alcohol consumption. All these are the most important predisposing factors for the tumors to develop. Coming to the tumors of the nasal cavity, it can be divided into benign and malignant. So what are all the benign tumors of the nasal cavity? They are squamous papilloma, inverted papilloma, pleomorphic adenoma, schwannoma, meningioma, hemangioma, Condroma, angiofibroma, encephalocele, glioma, and dermoid. Amongst this, the most important thing which you people have to know about is about the inverted papilloma, hemangioma, angiofibroma, glioma, encephalocele, and dermoid. These are the important things. With the exam point of view, these are the important benign tumors you should be knowing. Coming to the malignant tumors, the most common malignant tumors that can occur within the nasal cavity are the squamous cell carcinoma, adenocarcinoma, malignant melanoma, olfactory neuroblastoma, hemangiopericytoma, lymphoma, plasmacytoma, and various other types of sarcoma. Coming to the squamous papilloma, it is the benign lesion which is verrucous in nature. They are always similar to the skin warts. You can see here. And the site of the squamous papilloma to occur is over the nasal vestibule here. This is the nasal vestibule, and it can occur on the anterior part of the nasal septum. So this picture is showing the squamous papilloma which has developed over the anterior part of the nasal septum. So it can be either single or it can be multiple in nature. You can see multiple squamous papilloma here, and you can see a single squamous papilloma here. And it can be either sessile or pedunculated. So the treatment for the squamous papilloma is a local excision with cauterization of the base. Why do you cauterize the base? After the local excision, it is to prevent the recurrence of the squamous papilloma. We cauterize the base of the lesion. And also you can also go ahead with the cryosurgery or the laser. Next, coming to the very much important benign tumors of the nasal cavity, that is the inverted papilloma. So the inverted papilloma is also known as the transitional cell papilloma, Ringer's tumor, and Schneiderian papilloma. So this is the picture showing the inverted papilloma. Why is it named so? It is named so because microscopically the neoplastic epithelium which has been formed is seen to grow towards the underlying stroma rather than on the surface. That is why it is known as the inverted papilloma. So inverted papillomas are the nasal tumors that can originate within the mucous membrane of the nasal cavity and the paranasal sinuses. The mucous membrane of the nasal cavity and the paranasal sinuses are also known as Schneiderian membrane. Therefore, the inverted papillomas are otherwise known as Schneiderian papilloma. And these tumors are locally aggressive. They tend to recur and they can also become malignant in future. So what is the difference between the squamous papillomas and the inverted papilloma? The squamous papilloma are benign epithelial tumors that will grow outward in a finger-like projection within the nose, and the commonest site for those to occur is over the nasal vestibule and over the anterior part of the nasal septum. Whereas inverted papilloma, these projections, they grow inwards. The neoplastic epithelium which has been formed, they grow inwards towards the underlying stroma, and they also have got the tendency to invade the underlying bone. So inverted papilloma is also a rare benign tumor with the incidence rate of about 0.6 cases per 100,000 people per year. It comprises of 0.5 to 4% of all the primary nasal tumors, and the most commonest age to present with inverted papilloma is between 40 to 70 years of age, and it has got the male preponderance with a ratio of about 5:1. So inverted papilloma will usually arise from the lateral nasal wall in the middle meatus, and they often extend to the ethmoid and the maxillary sinuses. In the advanced cases, the extension into all of the ipsilateral peripheral nervous system may occur, but intracranial growth and dural penetration will be very much rare. And typically, the Schneiderian papillomas or inverted papillomas are unilateral, and bilaterally it can also occur. In the presence of the bilaterality, clinical evaluation should be done to exclude the possibility of the extension from unilateral disease. So what is the cause for the inverted papilloma? The proposed causes for the inverted papilloma is the human papilloma virus with viral strains of 6, 11, 16 and 18, and the other cause can also be because of the Epstein-Barr virus infection. So, the ectodermally derived lining of the sinonasal tract, which is termed as Schneiderian membrane, will give rise to the three morphologically distinct benign papillomas, that is the inverted papilloma, oncocytic papilloma, fungiform papilloma. The oncocytic papilloma is also known as cylindrical or columnar cells papilloma, and the fungiform papilloma is also known as exophytic or the septal papilloma. Amongst these, the inverted papilloma is the most common subtype, and the oncocytic type is the least commonest type. So what are all the clinical features of the inverted papilloma? The inverted papilloma can give rise to the nasal obstruction. So any mass which is occupying the nasal cavity, the very first symptom that the patient can present is with the nasal obstruction. So if at all there is any mass occupying the nasal cavity or the nasopharynx, obviously it can give rise to the hyponasal speech. And if the mass is spreading towards the adjacent structures, it can result in the facial swelling, and it can also cause epistaxis or the blood-stained discharge, and it can cause pressure and pain, rhinorrhea, and orbital symptoms like proptosis, diplopia, and epiphora if at all there is any invasion within the orbital contents, and hyposmia or anosmia can also be seen as the air currents cannot reach up to the olfactory area. So the most important clinical features are nasal obstruction, epistaxis, rhinorrhea, orbital symptoms, and hyposmia and anosmia. Signs. Usually it will present as a polyp and it can be mistakenly treated as a polyp. So it is reddish or pinkish in color and it is solitary, which has got the granular and friable surface, and it is a mass which arises in the region of the middle meatus in the lateral wall of the nose. It may bleed on touch, and extension to the surrounding sinuses or the orbit can lead to the facial swelling and the proptosis. If at all there is any evidence of the bony erosion in the CT scan, then the malignancy should be suspected. So this is the picture showing the inverted papilloma, which is solitary in nature, which is pinkish or red in color, and it has got the granular surface which is very much friable. Okay. So coming to the histopathology, you can see the thickened epithelial covering and the epithelial invasion and there is an extensive invasion of this hyperplastic epithelium into the underlying stroma. So behavior of the invasion into the underlying stroma has been theorized to be due to an origin from the Schneiderian membrane. Malignancy, in case of malignancy, the bony invasion can be seen. So what are all the differential diagnoses for the inverted papilloma? For antroconal polyp, allergic fungal sinusitis, squamous cell carcinoma, adenocarcinoma, and esthesioblastoma. These are all the differential diagnoses for the inverted papilloma. So what is the investigations that we can go ahead with that can do for inverted papilloma? First is the radiological investigation, where X-ray of PNS can be done to see the involvement of the sinuses and also to see the associated bony erosion, and CT scan with the coronal and axial sections. It helps in depicting the accurate extension of the tumor as well as the bony erosion, and DNE can be done, that is the diagnostic nasal endoscopy, which also helps in taking the biopsy. These are all the investigations for inverted papilloma. So what is the treatment for inverted papilloma? Wide surgical excision with cauterization of the base to prevent the recurrence can be done, and medial maxillectomy is also one of the treatment of choice, and midfacial degloving can also be done. If at all the lesion is very much small, it can be excised endoscopically with the help of laser. So the very commonly done treatment is the wide surgical excision with the cauterization of the base, and next is the medial maxillectomy if the tumor is very much vast, or if the tumor is even more vast, the midfacial degloving can be done, and if the lesion is very much small, it can be excised endoscopically with the help of laser. If at all the histopathological examination shows the malignant change, it should be treated as the carcinoma of maxilla. So next type of benign tumor of the nasal cavity is the pleomorphic adenoma and schwannoma. So pleomorphic adenoma is a very rare tumor. It arises from the septum, and the treatment for this is the wide surgical excision. And for schwannoma and meningioma is also uncommon. It is intranasal, and the treatment is the surgical excision. Next, coming to the hemangioma, the types of hemangioma of the nasal cavity are capillary hemangioma and cavernous hemangioma. The capillary hemangioma is also known as the bleeding polypus of the septum. It is soft, dark red in color, and it is pedunculated or sessile in nature. It is seen to be arising from the anterior part of the nasal septum. This is the capillary hemangioma. It is usually smooth, but it can become ulcerated and present with a recurrent epistaxis and also with the nasal obstruction. And treatment for this capillary hemangioma is the local excision with the cuff of a surrounding mucoperichondrium, and this is also done to prevent the recurrence. Next is the cavernous hemangioma. This hemangioma arises from the turbinates on the lateral wall of the nose, and this is treated with the help of surgical excision with cryotherapy. And extensive lesions can be treated by the radiotherapy as well as by surgical excision. Next, coming to the Condroma, which is the other type of benign lesions of the nasal cavity. So this Condroma can arise from the ethmoid sinus, nasal cavity or the nasal septum. The pure Condromas are smooth, firm and lobulated. It is smooth and it is also firm in nature and it is lobulated. Others can be mixed type, that is fibro, osteo or angiochondromas, and treatment of the chondroma is the surgical excision. Next, coming to the angiofibroma. Angiofibroma is actually a nasopharyngeal tumor. It is supposed to arise from the posterior part of the nasal cavity near the sphenopalatine foramen. This angiofibroma is discussed in the next nasopharyngeal tumors. Next, coming to the intranasal meningoencephalocele. So, it is one of the congenital disorder of the nasal cavity. What is this meningoencephalocele? It is nothing but the herniation of the brain tissues and the meninges through the foramen cecum or the cribriform plate. And the appearance of the meningoencephalocele is smooth polypoid type, which is present most commonly in the upper part of the nose between the septum and the middle turbinate. So this is the picture of the encephalocele, which is smooth polypoidal type, which is seen most commonly towards the upper part of the nasal cavity. And it is usually seen in the infants and the young children, and this mass increases in size on crying or on doing any strenuous exercises or on straining, because it is the mass which is herniating from the cranial cavity. So any increase in the intracranial pressure will give rise to increase in the mass within the nose on crying or on straining. So this can be misdiagnosed as a simple polyp and is mistakenly avulsed, resulting in CSF rhinorrhea or meningitis. So the biopsy should not be taken for the same reason. Investigation, the MRI can be done, which shows the meningoencephalocele herniating from the skull into the prenasal space. So this is the meningoencephalocele. So CT scan is required to demonstrate any skull-based defect or any defect at the level of cribriform plate. So the treatment for this is the frontal craniotomy, severing the stalk from the brain and repair of the dural and the bony defect. Intranasal mass is removed as secondary procedure after the cranial defect has been sealed. Next, coming to the glioma. Of all gliomas, 30% of them are intranasal and 10% are both intra and extranasal. These are most commonly seen in the infants and children, and they also present as a firm polyp, sometimes protruding at the anterior nares. So this is the picture showing the extranasal glioma, and this is the picture which is showing the intranasal glioma. So histopathological examination of the glioma mass will show the astrocytic neuroglial cells. These are the astrocytic neuroglial cells which are interlaced with the fibrous and the vascular connective tissue. These are the fibrous tissue and the vascular tissue, and in between are the astrocytic neuroglial cells. So the treatment of the nasal glioma is the complete surgical excision. Osteoma and inverted papilloma are the first and second most frequent benign tumors of the sinonasal tract respectively. Next, coming to the nasal dermoid. So this is the picture showing the nasal dermoid with the sinus present. So it presents as a widening of the upper part of the nasal septum with splaying of the nasal bones and also hypertelorism. So you can always see a pit or the sinus within the midline of the nasal dorsum with the hair protruding from the opening. So this is the expansion of the nasal bones, where you can see the pit or the sinus over the nasal dermoid. And this picture is showing the tuft of hair on the dorsum and also the healing discharge near the medial canthus of the right eye here. And treatment, the surgical strategy depends on the location and the extent of the lesion, ranging from the local excision to a combined intracranial and the extracranial approach. Recurrence is always uncommon and it is often easily managed. So these are the pictures showing the differentiation between the encephalocele. Encephalocele is nothing but the herniation of the brain tissues through the patent foramen cecum. Okay, and this is the glioma. The glioma can occur usually in the 3rd to 8th week of intrauterine life. Always the cranial tissues, they herniate through the foramen cecum, they oppose the ectoderm, and they again go back within the 8th week of intrauterine life. If at all the foramen cecum, after the herniation of the cranial cavity, if the foramen cecum closes early, then this neural tissues, they retain within the prenasal space, and they give rise to the glioma. And this is the dermoid fistula. I think Dr. Soumya has taken about the congenital disorders of the nose. Okay. Next, coming to the malignant neoplasms. Malignant neoplasms are the squamous cell carcinoma, adenocarcinoma, malignant melanoma, olfactory neuroblastoma, hemangiopericytoma, lymphoma, plasmacytoma, and other types of sarcomas. Primary carcinoma of the nasal cavity is very rare. It can be an extension of the maxillary or the ethmoid carcinoma. The squamous cell carcinoma is seen in about 80% of the cases, and rest of them are adenocarcinoma. So coming to the squamous cell carcinoma, the site of squamous cell carcinoma to occur is over the vestibule of the nose, anterior part of the nasal septum, or the lateral wall of the nasal cavity. It most commonly occurs around 50 years of the age with male predilection. So in the vestibular type of squamous cell carcinoma, the usual site is over the lateral wall, and it can also extend into the columella, nasal floor, and the upper lip. And it can metastasize to the parotid lymph nodes. So this is the picture showing the squamous cell carcinoma of the vestibule, where you can see the tumor neoplasm involving the columella and the floor of the nasal vestibule. So the septal type of squamous cell carcinoma, mostly it is over the mucocutaneous junction, and the symptoms are the burning and soreness sensation in the nose, and it is often termed as nose pickers cancer, and it is of usually low grade tumor. Lateral wall is also a most common site to be involved. It extends easily into the ethmoid or the maxillary sinuses. Grossly, it will present as a polypoid mass in the lateral wall, and metastasis is very rare. The treatment for this is the radiotherapy and the surgery, and radiotherapy, if at all it's given, it is given in 50 garants in 25 fractions to the nasal cavity. Next, coming to the adenocarcinoma. Adenocarcinoma arises from the glands of the mucous membrane or the minor salivary glands. It mostly involves the upper part of the lateral wall of the nasal cavity. The treatment is the complete surgical removal, and radical procedures are rarely needed. Radiotherapy is always optional. Metastasis of adenocarcinoma of the nasal cavity is unusual, and death of the disease is very much rare. Next, coming to the malignant melanoma. Malignant melanoma usually occurs around 50 years of the age, where both genders are equally affected. So this is a picture showing the malignant melanoma in the left nasal cavity. It is gray, blackish or gray in color. So grossly it appears slaty or grey or bluish black polypoidal mass. The most commonest site is over the anterior part of the nasal septum. Next most commonest site is the middle turbinate, and next is the inferior turbinate. So amelanotic type varieties are non-pigmented, and spread of tumor is by the lymphatics and by the bloodstream. And treatment of malignant melanoma is wide surgical excision. Radiotherapy and chemotherapy can suppress the immune system, and therefore they are avoided, and immunological defenses, they play a greater role in the control of the disease. It has got the 30% 5-year survival rate. Next, coming to the olfactory neuroblastoma, it is also known as the esthesioneuroblastoma, and it is a very rare tumor that develops over the upper part of the nasal cavity. It is thought to arise from the neural tissue associated with the sense of smell, and it is a tumor of the olfactory plug cord, which is seen in either of the gender at any age group. So it presents as a cherry red polypoidal mass in the upper third of the nasal cavity, and it is a vascular tumor and it bleeds profusely on biopsy. So lymph node or systemic metastasis can also occur, and it is a moderately radiosensitive tumor and it is cured by radiation alone. And the preferred surgical treatment for olfactory neuroblastoma is the endoscopic endonasal approach. And the advantage of this is there is no disfigurement and it has also got the faster recovery time. Next, coming to the hemangiopericytoma, this is a very rare tumor which has got the vascular in origin, and it arises from the pericyte. So pericyte is nothing but a cell which is surrounding the capillaries. So hemangiopericytoma arises from the pericyte. So it usually occurs between 60 to 70 years of age, where the patient usually presents with epistaxis. So this is a picture showing the hemangiopericytoma. So it can be benign or malignant, and which cannot be distinguished histologically. The treatment for hemangiopericytoma is wide surgical excision. Uh, Radiotherapy can be opted for inoperable or recurrent lesions. Next, coming to the lymphoma. Lymphoma, if at all it's occurring, it is non-Hodgkin's type, which usually presents over the septum. Next is the plasmacytoma. It is solitary in nature, which is seen within the nasal cavity, which predominantly affects the males over the 40 years of age. And the treatment for this is radiotherapy followed 3 months later by the surgery if total regression has not occurred. Next, other types of tumors are the sarcomas. It can be osteogenic sarcoma, chondrosarcoma, rhabdomyosarcoma, angiosarcoma, malignant histiocytoma. These are the other rare tumors that are affecting the nose. Thank you. On an exam point of view, the most commonest type of lesions that you people have to know is about inverted papilloma. One second. Yeah. So you should know about the first about the tumors of the nasal cavity, about the benign nature and the malignant nature, the commonest features of the benign lesions and the commonest features of the malignant lesions. This main thing you people should know. And next, in benign lesions, the most important thing which you people have to know about is the inverted papilloma, hemangioma, angiofibroma, encephalocele, glioma, and dermoid. Okay, the inverted papilloma, the difference between the squamous papilloma and inverted papilloma, you people should know, and the causes for squamous papilloma and the causes for the inverted papilloma, and what are the other synonyms for inverted papilloma that you people should know, and next is the clinical features of the inverted papilloma, the types of inverted papilloma people should know, and also the investigations of choice for the inverted papilloma and the treatment of choice for the inverted papilloma that you people should know. And next which you people have to know about is the angiofibroma. This will be discussed in detail in the nasopharyngeal tumors. Okay, and next you people should know about the differentiation of the encephalocele, glioma, and dermoid. These are the congenital tumors that can occur. I think Dr. Soumya has taken about these encephalocele, glioma, and dermoid. Okay, and coming to the malignant lesions, most importantly, you should be knowing about the squamous cell carcinoma, adenocarcinoma, malignant melanoma, and olfactory neuroblastoma. If you people know about this much, I think you people will be very much well versed with tumors of nasal cavity. Okay, any doubts? Okay, if all there are no doubts, then we'll wind up the class. Thank you.